Mental health and mental illness are difficult terms to define. Those who are able to carry out their daily functions, like going to work or school, whose behavior is appropriate, are considered to be healthy, while those who are unable to do those things are not. While there is no one definition of mental health, the World Health Organization, or WHO, defined mental health as a state of well-being in which the individual realizes his or her own abilities, can cope with the normal stresses of life, can work productively and fruitfully, and is able to make a contribution to his or her community. WHO stresses that mental health is not just the absence of a mental disorder. Individual factors include your biologic makeup, worries and fears, and inability to distinguish fantasy from reality. Interpersonal factors include ineffective communication, excessive dependency, and no sense of belonging. Social and cultural factors include poverty, violence, racism, and a lack of resources. Mental illness includes disorders that affect mood, behavior, and thinking, and includes illnesses such as depression, anxiety, schizophrenia, addictions, and so forth. They can make life seem overwhelming and may indicate signs of distress and impaired functioning. Daily life may feel overwhelming. For example, a depressed person frequently has trouble getting out of bed because they feel that life is too hard. General criteria for diagnosis of a mental illness includes a dissatisfaction with characteristics, abilities, and accomplishments, ineffective or unsatisfying relationships, dissatisfaction with one's place in the world, ineffective coping with life events, and a lack of personal growth. The Diagnostic and Statistical Manual of Mental Disorders is a manual that's published by the American Psychiatric Association, and it was last revised and published in 2013. The DSM gathers the latest empirical evidence and the recommendation of clinicians to create useful categories for the diagnosis and treatment of mental disorders. The diagnostic categories are also used for statistical data collection and as a guide for the coding of diagnoses for billing. A history of the DSM. Back in 1840, when the census was being taken, it was the first attempt in the United States to gather information about mental health by recording the frequency of idiocy and insanity during the census. By the time of the 1880 census, there were 7 categories of mental health, and these were mania, melancholia, monomania, paresis, dementia, dipsomania, and epilepsy. In 1917, the American Medico-Psychological Association and the National Commission on Mental Hygiene developed a plan to gather uniform health statistics across mental hospitals, but was mostly administrative classifications. Now there were 22 separate diagnoses in this version. In 1921, the American Medico-Psychological Association changed its name to the American Psychiatric Association, or APA. It collaborated with the New York Academy of Medicine to develop a nationally acceptable psychiatric classification that would be incorporated within the first edition of the American Medical Association Standard Classified Nomenclature of Disease. This system was designed primarily for diagnosing inpatients with severe psychiatric and neurological disorders. After World War II, the Army developed a broader classification system to address presentations from the war and veterans, like psychophysiological, personality, and acute disorders. At the same time, the World Health Organization published ICD-6, which is the International Classification of Diseases, that included a section on mental disorders for the first time. In 1952, the APA Committee on Nomenclature and Statistics developed a variant of the ICD-6, and this was the first edition of the DSM. There were 106 mental disorders in this version. DSM-2 was published in 1968 and had 182 disorders. DSM-3 was published in 1980 with some important innovations: explicit diagnostic criteria, a multi-axial diagnostic assessment system, and an approach that attempted to be neutral with respect to the causes of mental disorders. DSM-3 was developed with the additional goal of providing precise definitions of mental disorders for clinicians and researchers. DSM-3 had 265 diagnoses in this version. The multi-axial system included Axis 1, which were the clinical disorders or the mental illness. Axis 2 is personality disorders and mental retardation. Axis 3 included general medical conditions such as diabetes or heart failure. Axis 4 are the psychosocial and environmental problems such as divorce, poverty, homelessness, and so forth. And Axis 5 is the GAF score, or the Global Assessment of Functioning, and it's a number from 0 to 100. 0 is not functional, and 100 is optimal. DSM-4 was published in 1994. There were many changes made to the classification. Disorders were added, deleted, and reorganized. And there were 297 diagnoses in DSM-4. DSM-5 is the version that we deal with. It was published in 2013. The multi-axial system was eliminated, and chapters were organized to show how disorders relate to each other. DSM-5 introduces the concept that mental illness exists on a spectrum from normal to severe, and it uses subtypes and specifiers. There are 3 purposes to the DSM, and these are important for you to know. These 3 purposes are to provide standardized nomenclature and language for all mental health professionals, to present defining characteristics of symptoms that differentiate specific diagnoses, and finally, to assist in identifying the underlying causes of the disorders. Historical perspectives on mental illness. Sickness was seen as a punishment for sins and wrongdoing. Those who had a mental disorder were viewed as being either divine or demonic, depending on their behavior. Those that were seen as divine would be worshipped, while those that were seen as demonic would be punished, which sometimes meant they were burned at the stake. Aristotle tried to relate mental disorders to physical disorders and thought the 4 humors of black bile, yellow bile, water, and blood controlled the emotions. Imbalances of the 4 humors were believed to cause mental disorders, so treatment was aimed at restoring balance through bloodletting, starving, and purging. Such treatments persisted well into the 19th century. Hippocrates recognized distinct categories of mental illness that included melancholia, mania, and paranoia. Persian and Arabic scholars translated the works of the Greeks and Romans, and they expanded the diagnostic the diagnostic categories to include delusional disorders, anger, and aggression, and others. The first psychiatric hospital was established in Baghdad in 705 AD. Mental illness was believed to be caused by jinn, or special creatures that can possess a person. The early Christians viewed mental illness as being possessed. They distinguished between idiocy and lunacy, and the cause was believed to be evil forces. Priests would perform exorcisms to get rid of the evil spirits. If that didn't work, they would use increasingly severe measures, like sending the person to the dungeons, floggings, or starving them. In England during the Renaissance, which is about 1300 to 1600, the mentally ill were distinguished from criminals and were allowed to wander the countryside or to live in rural communities. If they were considered to be a dangerous lunatic, then they would be thrown into prison, chained, and starved. The Hospital of St. Mary of Bethlehem, which was nicknamed Bedlam, was founded in 1247 by an Italian bishop named Goffredo di Prefereti and was built directly on a sewer that overflowed. Originally, it was intended to collect money to help with the Crusades, but the monks took in the indigent who were frequently mentally ill. It was declared a hospital for the insane in 1547 and was the first of its kind. In 1775, visitors were charged a fee and they could come into the hospital and ridicule the inmates. Over time, the treatments grew increasingly worse. Some of the treatments there included rotating, where a person was put into a chair that was hung from the ceiling and then spun, sometimes over 100 rotations a minute. Bloodletting, ice baths, and cupping. Many patients died, and there are mass graves on the property. The hospital does still exist today, although the treatment today is much different than it was. It is known today as the Bethlehem Royal Hospital. During this time, the colonies in the Americas were established. The mentally ill in the Americas were seen as evil or possessed and were punished. Witch hunts occurred, and offenders were burned at the stake. In the 1790s, the period of enlightenment for mental illness began. Philippe Pinel in France and William Tuke in England began the concept of asylums as a place of refuge that offered protection, beginning a movement of moral treatment for the mentally ill. Philippe Pinel made humane changes to the conditions under which the mentally ill people were held. Rather than being held in chains in squalid conditions, his patients were free to move about in clean, relatively pleasant environments. Pinel categorized different types of mental illness and recognized that some were curable and some were not. He documented therapies that cured patients and recommended that physicians keep case notes to both understand the illnesses and to evaluate the effectiveness of therapies. Some changes made by Pinel included stopping ancient treatments like bloodletting, recognizing that patients are people with problems rather than seeing them as lunatics, stopping paid visits from the public to ridicule the patients, and he saw his patients daily and talked to them. A quote from Pinel: "Far from being sinful people who deserve to be punished, the insane are sick people whose unhappy state deserves all the sympathy that is owed to the suffering humanity." William Tuke was born in York on the 24th of March, 1732, into a leading Quaker family. He entered the family tea and coffee merchant business at an early age. He also devoted much of his time to the mission of philanthropy. When a Quaker died in the squalid and inhumane treatments in the York Asylum, Tuke was invited to visit and was appalled by what he saw there. In 1776, he began to raise sufficient funds to open the York Retreat for the care of the insane. This was the first facility in England with expectations for proper treatment of their patients. These included removing the inmates' chains, keeping them in a clean environment with decent food, and adopting a program involving the therapeutic use of occupational tasks. Tuke's ideas were similar to those of Pinel's, although the two men never worked together. William Tuke modeled care with the idea that the mentally ill were equal human beings, and they were to be treated with gentleness, humanity, and respect. Ideas like Tuke's and Pinel's were groundbreaking, and the retreat focused on the healing of the mentally ill. The treatment used in both the York Retreat are still continued in hospitals today and played a large role in the movement towards humane treatment. In 1836, Dorothea Dix traveled to England with some friends and returned home months later with an interest in new approaches to the treatment of the insane. She took a job teaching inmates in an East Cambridge prison where conditions were so abysmal and the treatment of prisoners so inhumane that she began agitating at once for their improvement. Prisons at the time were unregulated and unhygienic, with violent criminals held side by side with the mentally ill. Inmates were often subject to the whims and brutalities of their jailers. Dix visited every public and private facility she could assess, documenting the conditions she found with unflinching honesty. She then presented her findings to the legislature of Massachusetts, demanding that officials take action toward reform. Her reports, filled with dramatic accounts of prisoners flogged, starved, chained, physically and sexually abused by their keepers, and left naked without heat or sanitation, shocked her audience and galvanized a movement to improve conditions for the imprisoned and insane. As a result of Dix's efforts, funds were set aside for the expansion of the state mental hospital in Worcester. Dix went on to accomplish similar goals in Rhode Island and New York, eventually crossing the country and expanding her work into Europe and beyond. She was instrumental in opening 32 state hospitals. Unfortunately, the period of enlightenment lasted only about 100 years. The state hospitals began to have trouble, and attendants were accused of abusing the patients. Because the hospitals were in rural locations, they were seen as isolating the patients from their families and homes, and the phrase insane asylum took on a negative meaning. Sigmund Freud was the first to start the ball rolling with the scientific study of psychiatry and diagnosing and treating mental illness, along with Emil Kraepelin and Eugene Bleuler. Freud studied the mind, its disorders, and their treatment in a way that no one had done before. Other theorists built on his work. Kraepelin began classifying mental disorders by their symptoms, and Bleuler came up with the term schizophrenia. Things really changed in 1950 with the breakthrough of thorazine and lithium, which were used to treat mental illness. A series of successful antipsychotic drugs were introduced that do not cure psychosis, but they do help to control its symptoms. The first of the antipsychotics, the major class of drug used to treat psychosis, was discovered in France in 1952 and was named chlorpromazine or thorazine. Within 10 years, drugs like Haldol, tricyclic antidepressants, and benzodiazepines were also introduced. It's estimated that about 43.7 million adults have a mental illness. In the last year, 20.7 million people had a substance abuse disorder, and 8.4 million of those had a co-occurring mental illness, making them what we call a dual diagnosis. Mental illness, or serious emotional disturbances, impair daily activities for an estimated 15 million adults and 4 million children and adolescents. With kids and adolescents, it's diseases like ADHD. More than 10 million children under 7 grow up in homes where at least one parent has a mental illness or substance abuse. 1 in 4 adults and 1 in 5 children and adolescents requiring mental health services actually get the care they need. The economic burden of mental illness is greater than the burden caused by all types of cancer. Mental illness is the leading cause of disability in the United States and Canada for those 15 to 44 years old, and an increasing number of both adults and children are being treated for mental illness. It's good that more people are being treated, but there is still a stigma about mental health, and it goes undiagnosed for many still. The increasing numbers also tax the system. Mental illness is very expensive to treat because treatment occurs over such an extended period of time. The idea to treat those with mental illness closer to home also took root. Deinstitutionalization is the process of replacing long-stay psychiatric hospitals with less isolated community mental health services for those diagnosed with a mental disorder or a developmental disability. President John F. Kennedy's 1963 Community Mental Health Centers Act accelerated the trend towards deinstitutionalization with the establishment of a network of community mental health centers. The trend continued into the 1970s with the implementation of the Supplemental Security Income Program in 1974 and Social Security Disability Income. These programs allowed those with a disability to be more financially independent and not rely on their families. State governments helped accelerate deinstitutionalization, especially of elderly people. There were changes in commitment laws in the early 1970s, making it more difficult to commit people for mental health treatment against their will. This further decreased the state hospital population, and consequently the money that states spent on them. Deinstitutionalization has its pros and cons. Although it reduced the number of hospital beds by 80%, the number of admissions to those beds has increased by 90%. Patients have shorter hospital stays, but end up getting readmitted more frequently, creating the revolving door effect. This constant flow of patients in and out overwhelms the hospital units, which increases the visits of mentally ill to the emergency department. Then, those patients have to stay in the ER until a bed can be found for them on an inpatient unit. Short stays can complicate the repeated admissions. For people with severe and persistent mental illness, they may show signs of improvement after a few days, but may not be truly stabilized. They are then discharged into the community, but may not yet be able to cope. For those with both substance abuse and mental illness, alcohol and drugs can exacerbate their symptoms, which make rehospitalization more likely. Substance abuse issues can't be adequately dealt with in a 3 to 5 day admission. Homelessness is a major problem in the United States today. 1/3 of the adult homeless population are estimated to have a serious mental illness, and more than half also have substance abuse problems. 610,000 people, 140,000 of which are children, are homeless on any given night. Those who are homeless and mentally ill are frequently found in parks, the airport, bus terminals, alleys, jails, and so forth. Some use shelters or halfway houses or a cheap hotel if they can afford it. Homelessness makes many mental illnesses worse. How do you get your medications or get yourself to your appointment if you're homeless? How can your mental health care center find you if you're homeless? Many people also have comorbidities with their mental illness, and there's never enough community resources to service all those who need them. Homelessness and mental illness are risk factors for frequent emergency room visits, and visits for these populations have been increasing. Nurses have to be prepared to care for this culturally diverse population, which includes being aware of cultural differences that influence mental health and its treatment. Objectives for Healthy People 2020 include to reduce the suicide rate, reduce the suicide attempts by adolescents, reduce the proportion of adolescents who engage in disordered eating behaviors and in an attempt to control their weight, reduce the proportions of people who experience major depressive episodes, increase the proportion of primary care facilities that provide mental health treatment on-site or by paid referral, increase the proportion of juvenile residential facilities that screen admissions for mental health problems, increase the proportion of adults with mental health disorders who receive treatment, increase the proportion of people with serious mental illness who are employed, increase the proportion of people with co-occurring substance abuse and mental health disorders who receive treatment for both disorders, increase depression screening by primary care providers, increase the number of homeless adults with mental health problems who receive mental health services. Community mental health centers were developed in response to deinstitutionalization. They serve a smaller geographic area, which allows patients to be closer to home and their families. They may provide emergency care, inpatient care, outpatient services, partial hospitalization, screening services, and education. 2,000 community mental health centers were supposed to be built by 1980. By 1990, there were only 1,300 programs that provided various types of psychosocial rehabilitation. Those with severe and persistent mental illness were either ignored or underserved. Many people that needed services were not getting them, and this continues today. In 2015, the Treatment Advocacy Center reported that about half of those with severe mental illness did not get treatment of any kind in the previous 12 months. Community mental health programs were developed to meet the needs of people with mental illness outside the walls of an institution. These programs focus on rehabilitation, vocational needs, education, socialization, management of symptoms, and medications. Services are funded by states, counties, and private agencies. Availability and quality of services therefore varies. Rural areas have smaller numbers of people requiring services, but less money to provide them. Larger areas will have a larger budget, but also have higher demand. There is never enough money to provide all the services that the area needs. As healthcare costs increased in the 1970s, managed care came in. It tried to balance the quality of care with the cost of care. In a managed care system, people get care based on need rather than on request. In the 1990s, a new form of managed care was developed by utilization review firms, or managed care organizations, to control the expenditures of insurance money by requiring approval of care before delivery of care, or pre-approval. This became known as case management, an effort to provide needed care while containing cost. Each patient is assigned a case manager who coordinates the care needed by that patient. It's designed to decrease fragmented care, eliminate overlap, provide care in the least restrictive environment, and decrease costs. In reality, costs are often managed by substituting less expensive procedures or withholding care. Psychiatric care is expensive due to the long-term nature of the disorders. A single hospital stay can cost $20,000 to $30,000. There are fewer objective measures in healthcare as well. You don't know if a patient is suicidal unless they tell you they are. It's not something measurable. Mental health is also separate from physical care in insurance coverage. Insurance frequently has dollar limits or a limited number of days in a year. Mental health care is managed through privately owned behavioral health care firms that often provide the services and manage costs. Those without private insurance rely on their county to provide funding, which comes from tax dollars. These services and the money to fund them often lag behind the need. Many of those with mental illness will avoid treatment. These people are often homeless or in jail. The Healthcare Finance Administration has two insurance programs, Medicare and Medicaid. Medicare covers people 65 and older, those with permanent kidney failure, and those with certain disabilities. Medicaid is funded jointly by federal and state government to cover low-income people and families. Another funding issue is mental health parity or equality in insurance coverage for both physical and mental illness. In the past, insurers had spending caps for mental illness and substance abuse treatment. Some had dollar limits while others limited days. In 1996, Congress passed the Mental Health Parity Act, which eliminated annual and lifetime dollar amounts for mental health care for companies that had more than 50 employees. But substance abuse was not covered by this law, and some insurers choose not to cover mental illness at all. Nurses must be prepared to care for this culturally diverse population. Preparation includes being aware of cultural differences that influence mental health and the treatment of mental illness. That doesn't mean that you know every culture. That would be impossible. However, patients can be seriously disadvantaged if we don't have an understanding of their culture, so the patient's background and identity must be understood by the clinician. Culture influences many aspects of mental illness, including how a patient from a given culture expresses and manifests their symptoms, their style of coping, their family and community support, and their willingness to seek treatment. I once had a patient from a small community in Africa. She didn't speak any English, and it took 4 tries to find a correct interpreter so that we could actually understand what the woman was trying to say. She was brought in thinking that she was delusional and abusing her son. She had accidentally burned her son, and whoever reported her thought that he was being abused and burned intentionally. This woman was also pregnant, but wouldn't acknowledge the pregnancy. She had a strange way of phrasing it, saying that I do not acknowledge I'm pregnant. But nobody understood why. She was very obviously, visibly pregnant. Well, after the 4 tries to find a correct interpreter, I finally did find somebody who spoke the correct language, and we were able to communicate with this woman. It turned out that her culture had a practice of heating cloth and touching it to the child to ward off evil spirits. So, not being familiar with our ovens in the United States, she accidentally got this cloth too hot, and she did burn her son, but it was an accident, and it hadn't been repeated. So she was not actually abusing her son. But still, the psychiatrist was very concerned because she didn't acknowledge the pregnancy, and she was very obviously very pregnant. It was estimated she was about 8 to 8.5 months pregnant. I did not have time to do a lot of research on this patient's culture, but a social worker did have some time, and she did research this culture. And it turned out that women who went around saying that they were pregnant in this culture were branding themselves as a whore. So the way that she had put it, saying, I do not acknowledge I'm pregnant, she was just trying to not brand herself a whore. So she was eventually released after she had started having contractions during my shift, and I was quite concerned about delivering a baby on a psychiatric unit, but she was transferred over to labor and delivery where they were able to stop her contractions, and she was then able to go home with her family. So, psychiatric nursing practice. Linda Richards was the first American psychiatric nurse. She was born in an era of informal nursing. Nursing duties beyond those provided by family members typically fell to what were popularly called born nurses, which were women in the local community that were gifted with sympathetic natures and an appropriate combination of indefatigability and patience. Although Richards recognized that these characteristics were central to nursing, she also saw the value of formal training. Her own training began when she was a teenager, learning to assist the local physician who treated Richards' tubercular mother. Hoping for more formal nursing education, Richards joined Boston City Hospital, but was so discouraged by the experience that she left after only 3 months. In 1872, she enrolled in the new nurse training program established by Susan Dimick, who was an MD, at the New England Hospital for Women and Children, and in 1873, she became the program's first graduate. Nursing work in those days was extremely grueling. Nurses worked 16-hour shifts, were on call 24 hours a day, and were expected to clean and do laundry as well as care for their patients. Most nurses knew nothing about medicine or symptoms, and Richards was dismayed to see that physicians often regarded nurses as little more than maids. Another problem that Richards noted was that physician orders and nurses' reports were entirely verbal. She decided to present her notes in writing. One of the hospital's physicians so appreciated having written records that he pushed for it to become standard practice. Such written charts were later adopted throughout the United States and England. In 1874, Richards became the superintendent of the training school at Massachusetts General Hospital. Richards quickly made the program a great success, inviting outside lecturers, reorganizing the nursing staff, and finally delegating custodial duties to scrubwomen. She also assigned specially designated night duty nurses so the hospital's nurses would no longer have 24-hour-a-day responsibilities. In 1877, Richards was invited to Great Britain. There, she met Florence Nightingale. At the Royal Infirmary, Richards met and studied with Joseph Bell, best known today as the teacher of Sir Arthur Conan Doyle, and was the inspiration for Sherlock Holmes. After returning to the U.S. and establishing a training school at Boston City Hospital, Richards traveled to Kyoto, Japan. She spent 4 years in Japan working as a missionary and establishing that nation's first nurse training school. Richards came back to the U.S. in 1891 and went on to establish and run nurse training programs in Pennsylvania, Massachusetts, and Michigan. From 1899 to 1909, she turned her attention to training psychiatric nurses. Ill health prompted her to retire in 1911. McLean Hospital was founded in 1811 in a section of Charlestown, Massachusetts that is now part of Somerville, Massachusetts. Originally named Asylum for the Insane, it was the first institution organized by a group of prominent Bostonians who were concerned about homeless mentally ill people abounding on the streets and in byways in and about Boston. The effort was organized by Reverend John Bartlett, chaplain of the Boston Almshouse. The hospital was built around a Charles Bulfinch mansion, which became the hospital's administrative building. Most of the other hospital buildings were completed in 1818. The institution was later given the name the McLean Asylum for the Insane in honor of its earliest benefactors, John McLean, who granted enough money to build several such hospitals. A portrait of McLean now hangs in the present administration building along with other paintings that were once displayed on the original hospital. In 1892, the facility was renamed McLean Hospital in recognition of broader views of the treatment of mental illness. McLean Hospital in Belmont, Massachusetts, was the first place to train nurses to work with the mentally ill, and they began in 1882. Initially, it focused on nutrition, hygiene, and activity. Patients were treated with tolerance and kindness. The role of the nurse expanded as somatic therapies were developed. Treatments like insulin shock therapy in 1935, psychosurgery in 1936, and electroconvulsive therapy in 1937. McLean Hospital is a teaching hospital for Harvard University, for the medical residents there, and for the continued development of the Harvard faculty. Well-known former McLean patients include mathematician John Nash, musicians James Taylor and Ray Charles, poets Sylvia Plath, Robert Lowell, and Anne Sexton, and authors Susanna Kaysen and David Foster Wallace. Nursing Mental Diseases by Harriet Bailey was the first psychiatric nursing textbook and was published in 1920. In 1913, Johns Hopkins was the first school of nursing to require a course in psychiatric nursing, but it wasn't until 1950 that the National League for Nursing would require all nursing schools to include a psychiatric nursing experience. Two early nursing theorists shaped psychiatric nursing practice. Hildegard Peplau is our first nursing theorist. She shaped psychiatric nursing. She published Interpersonal Relations in Nursing in 1952 and Interpersonal Techniques, the Crux of Psychiatric Nursing in 1962. She described the therapeutic nurse-client relationship and its phases and wrote extensively about anxiety. The interpersonal relationship that was crucial to her beliefs forms the foundation of our practice today. Perhaps Peplau's most extraordinary accomplishment was the development of her theory on interpersonal relations. This impacted significantly on the establishment of psychiatric and mental health nursing as a clinical specialty. Psychiatric nursing led the field of nursing and was the model for the whole development of clinical nursing in the United States. As Peplau led psychiatric nursing out of the confinement of custodial care into a theory-driven professional practice, she inadvertently formed the backbone of nursing's professional development. Canadian nurse leader Cheryl Forchuk and others did a great deal of work on expanding Peplau's theory to include much more than just the individual. Taking Peplau's theory into the realm of home visiting, the inclusion of families, patient education, and of course into the practice of psychiatric and mental health nursing, Peplau's contributions to psychiatric mental health nursing continue to live on in the lives of our patients. The second nursing theorist is June Mello. In 1968, June Mello wrote Nursing Therapy. In that, she describes her approach of focusing on the patient's psychosocial needs and strengths. She felt that the nurse as a therapist is particularly suited to working with those with severe mental illness. The American Nurses Association developed standards of care, which are revised as needed. Standards of care describe the responsibilities that nurses are accountable for. The American Psychiatric Nurses Association has standards of practice and standards for professional performance. It also outlines areas of practice and the phenomena of concern, which include promotion of optimal mental and physical health and well-being and prevention of mental illness, impaired ability to function related to psychiatric, emotional, and physiologic distress, behaviors and mental states that indicate potential danger to self or others, emotional stress related to illness, pain, disability, or loss, societal factors such as violence, poverty, and substance abuse, and physical symptoms that occur along with altered psychological status. Areas of practice include both basic level functions and advanced level functions. Basic level functions include counseling through interventions, crisis intervention, problem solving, and behavior modification, milieu therapy through maintaining a therapeutic environment, teaching skills, and encouraging communication, psychobiologic interventions with giving meds, teaching, and observing, self-care activities through encouraging independence, increasing self-esteem, and improving function and health, and case management and health promotion and maintenance. Advanced level functions include psychotherapy, prescriptive authority for drugs, consultation and liaison, evaluation, program development and management, and clinical supervision.